areas that
Mickey's going. Yeah.
Okay, no more echo. This is people start to with different venues for everyone, and but quite a significant IT challenge. But I think we've worked through, and we have an IT expert who we're not going to let leave. Yet to be able to. So we're here to present. Claire was introduced. I'm introducing. Right, so we're here to talk about patients and complex patients. So I'm Claire Ransom, the Executive Developer. We also have Sam Tunby, who is Clinical Director of Subacute Aged Care and Focusing. Justin, who's just trying to get everything sorted.
Hospital home.
It's Hospital Home. Fantastic. I'll try and remember. And Sarah Ella is here from Manchester, Australia. Yes. Thank you very much. So we've each got some a brief, as a little briefer to tell you about Australian patient and about complex care, and then some case studies to kind of bring together what that looks like for us in day-to-day practice. So I'm going to hand over to Emma to start with. Who's going to talk about discharge pathways.
So I think we've structured this reasonably well, because I think we start with the really, really boring part of the presentation, because there is absolutely no way you can make discharge pathways exciting or interesting, but they are really important, and a general understanding of them can make your life much easier. So after me, we'll have Claire with some statistics.
Yep.
Marginally more interesting, slightly. Yeah. And then we're going to Justin. Yep. And who has a very exciting case study to talk about. And then we finally get to hear from Sarah, who is going to tell us about a really exciting initiative that has been put in place through the federal government and locally, and that is keeping some big goals for our patients who are trying to escape from the hospital system. Okay, cool. So as the Clinical Director of the Aged Care and Community Services and Patient Flow, I'm supposed to have a very, very clear understanding of discharge pathways, because they basically sit in some way, shape or form under either of those systems. But I will start with an apology, because I'm likely to make some sort of error during this, because these things are so complicated. All right, so on the next slide. Do you really want the next slide? Yes, I really want the next slide. Good. Okay, so where did you go?
I just tapped on the left side of this.
Okay, so this is what we want discharge planning to look like. We want it to be clear. We want to know how to get our person to the next step in their care. And we want it to be really, really easy to understand. But in fact, this is what it looks like. It requires specialised knowledge of a multitude of systems. It feels sometimes like you need to understand complex maths level of detail to be able to navigate the systems that we have in place to have patients transition from one point of care to the next. So I have 10 minutes to talk about this. And so I am going to be completely glossing over a lot of the complexities and try to make it as simple as possible, with the idea that you might come away with some knowledge that you can find useful on a day-to-day basis. We all know that we have been taking a small amount of information in these sort of settings. So what the area that we're talking about is when the patient is, at the beginning of the patient's stay in hospital, you should be thinking about when they no longer need the care that they're at now, where are they going to go next? So they may be subacute, they may be in acute, they may be in one of our maintenance areas, but you should be thinking about where they need to go. And the people who are completely responsible at this point in time is the multidisciplinary clinical team who patients admitted. So this is not the bit where they get involved. This is where the expertise is sitting within your clinical team because you know the patient. So when you're trying to work out where they go next, you're going to have a small group of, no, hopefully a large group of patients who can just go home with no other interventions required. But increasingly, we have patients that need something else. So when I'm thinking about where they go next, I try and break it down into whether they're going to be able to go back to their normal home, whether they're going to need subacute specialty care before they go home, whether they need to go somewhere for a lower acuity stay for a period of time as a temporary stay. And the big thing is, are they going to need new accommodation? That's where we have our major challenges with respect to people staying from the hospital system. So, once they go home, we actually have a whole variety of care levels that we can provide. We can provide hospital level care through the Epsom team, which is incredibly important the day depending on where the person is. And they can provide complex nursing care and medical care. And then once they hit the acute service, which is the German, they get comprehensive services as well. And so, we have a variety of level care that we can actually provide in the future. The other group of care provisions we have is transitional care program, which is a federally funded initiative for 3 months. And it provides some health and nursing care to all the people in their homes. Community nursing is an option that we can have, and we've got people coming up giving generics doing wound care.
Yeah, I think to hear you, we need to schedule a bit. For the second, the microphones are in the ceiling, so that everyone wants to move closer to unless you want to stand on the chair. So we'll try and speak up a little bit more.
Goodness, it's difficult hearing me.
Yeah.
Okay. Then you have your home support, so your personal care, your domestic supports that we have, either on a short term or a longer term basis. And finally, we now have a new service. We have Care at Home, which can provide some telehealth support for patients who could get out if they had someone contacting them regularly to check and monitor their disease progression. Okay, so if they're not able to go home, they may need to go somewhere to get subacute specialty care. And the type of care you're talking about here, geriatrics evaluation and management. Okay. Rehabilitation, palliative care, and psychogeriatrics. So these are cares that are multidisciplinary care, primarily focused on optimizing the patient's function and quality of life, that are usually entered into after a period of illness. The next group that we had was lower acuity care. Now we have lots of options here. We have 10 Hobart private hospital maintenance beds. We have health beds. Those beds we have in Midland, Swansea, Dover, Davina, and we have a 14-bed district hospital at New Norfolk. In those environments, people can wait receiving care prior to going home, prior to going to subacute care, sometimes prior to returning for acute care. So we have people who go there for a period of time and get an operation at a later date. Then we also have our respite beds and interim care beds, which are located in residential aged care facilities. And finally, the options that we have for the residential aged care homes, that the NDIS and people we work on community housing. Community housing is not something that, well, housing is not something that health is obliged to engage in on a routine basis, but we recognise that for some of our vulnerable patients, that this is an area that we do need to get involved with. So once we've assessed our patient, we've worked out that they need to go somewhere else prior to going home to their final destination, or they need to go to a new final destination, we need to work out how to get them there. So again, I've tried to categorise it and break it down. And to be honest, we have a 70-page document that actually just describes this in great detail. So I've been trying to break it down to 3 steps. I'm being optimistic, but I have 3 different pathway approaches. So the first one is that you have a group of step transitions where you are being taken over by another medical team. Okay, so in the same way that you might fall on the ward and be taken over by orthopedics because you have a fractured neck or femur, you have a doctor talking to a doctor saying, I no longer am going to be able to care for this patient. This patient needs your subspecialty care, and they talk to each other and they have the takeover of care. So with that takeover of care process, it's the same process that happens in the hospital. It's by a med tasker, and it's usually undertaken by the medical staff in the clinical team. All of these services can take phone calls. When I've spoken to them, they prefer med tasker because it gives them a list and it gives them that whole team visibility of who it is that they're being to take over care. That's pretty easy. The next one we have is areas that we run completely within a hospital. So these are specialised teams that are nursing teams or nursing and allied health teams. And they tend to take the referrals from nursing and allied health. They use the Kyra system as their referral pathway, their preferred referral pathway. Again, these can all do MedTasker and they all have phone access as well. But if you see the way that they usually function, it is usually via Kyra. And the functional group that we the ones where we have external providers, and that's where everything goes absolutely crazy. And this is where you absolutely need your expert. The social worker is the usual person in this particular area who is an absolute expert. They have portals, they have phone calls, you've got to work out whether someone's over 65, under 65 to decide which service they're eligible. And there are a million rules around who can have what. Which brings me into the final slide, which is that is the traditional serenity prayer, that you need to have the serenity to accept the things you cannot change. You cannot put someone in an ICF if they're under 65, even though they may have an aged care problem, they may be 64, that may be the most appropriate place for it, because the federal government has said, if you're 62, you are NDIS. If you are under 65, you have eligibility for things that you will never get. The care need, the lady that Epson is going to talk about, you would never get that provided in some zone if you're over 65. Which interesting, you can keep talking. Yeah, so that's okay. And then, all right, here you go. Emma,
Okay, I think you can see that on screen. I think I can see it. Deirdre had a hand up, it's gone down, so hopefully you can hear the sound. I'm going to talk out, and Bridget's going to be my canary in the coal mine for when I get quiet again. Right, so I'm going to briefly cover on our work around stranded patient panel. You hopefully have heard a little bit about, and the broader complex patient program that we're rolling out. So interestingly, now the copies on my screen, I don't read my slides anymore, but at least you can see them, so that's helpful. So what was the problem? Well, as an organisation, we had poor visibility of patients who stayed longer than expected. We didn't really know why some people got stuck, and I'm using the word stranded because we took a lot of this program from the NHS model, which uses that term as well, so we're still using that term. But people who sort of were here, medically safe to discharge, no clear plan, or a plan that had really struggled to make that happen. Lack of escalation pathways have been worse. That's something that sort of got really stuck at a board level, not really clear as to how we would make this work or do the things we needed to do to get the person home or to where they needed to be. Really inconsistent processes, lots of workarounds, lots of trying to go around the problem without us being able to address it, and a lack of understanding of how we would work within the organisation, so internal referrals or internal processes as well as external. And this meant that we had patients who were staying much longer than necessary in a setting where bed demands are really high all the time, which felt like a problem we should probably have a think about. And it occurred at a period of time where we were running as an organisation a lot of rapid improvement projects. So basically this came up as a conversation and an idea, and we were up and running with the first round of patient meeting in 2 weeks. So we were really clear that this was not a perfect process. It was something we were going to have to adapt and change over time, but we just needed to start somewhere. This was the data that really, I think, reinforced that we had to do something. So on the top, you've got long stay bed days. This is Health Roundtable data. So our actual long stay bed days are the dark purple line in the middle. The bluish line is the median 50th percentile, and then you've got pink at 75th percentile and yellow at 25th. So you can see that we're tracking along below the median up until about start of 2023. And then we jump right up above 75th percentile. Not ideal. And then we look at acute relative stay index. So these are in our acute beds. Again, we're doing okay around the median, and then we jump up again. Not quite as high, but it's still less than where we'd like to be in our acute relative stay index is 105%. That Health Roundtable, all of hospitals is 99%. Our peers are below the 99%, so we know we're above, and we would like to do something about that. So initial project, we set up panels, multidisciplinary senior group. There's Emma, there's me, there's Danendra Gill started as well. So there's a clinical director of medical and cancer services. So we had some really senior medical in the room, and Joe Robertson as the aid-on for Max. We met weekly with a focus on the acute medical wards, 4 wards, 4 weeks. We met 1 ward per week. Our initial patient criteria was a greater than 35-day length of stay and a maintenance care type, with a goal of looking at and identifying and resolving barriers, escalating concerns, and educating teams through real in-the-moment working on problems. So we ran that from July, basically in that model-ish, through to December. This is the initial outcome. So this is over the first 8 weeks or so. We see the top line is the total patients under the 35 days for that 8-week period. It basically almost halves. We go from about 15 to 9, I think. And what we end up with after that period of time is not enough patients to talk about for each of the wards, which is a terrible problem. So we shift the criteria downwards and went to 21-day length of stay, which is really what we would want to do with the program over the whole, keep reducing down. So we're always talking about patients who are at risk of staying longer than they need to and resolving these issues. I'm starting to frame this here in terms of current complex patient program, because while stranded patient program panel is a really important part of it, there is more that we are doing and need to do, so under this sort of umbrella term. So at the moment, stranded patient panel, as of January this year, we've kept the panel. Basically, Joe Robertson's off doing something else. Kayla Gadd's come in. We meet weekly with all adult inpatient wards except WAPS and PAL Care. So we've expanded the wards across all adult inpatients, and we've adjusted the criteria. So mostly it's around 21-day or greater length of stay, any care type, or anybody who's at risk of a prolonged stay And often they're people who are experiencing homelessness, who might be on or eligible for NDIS, who might have suspected issues with decision-making capacity. And we've adjusted that slightly for sub-acute wards. And I think the nice part of that now is that the GEM wards, P1 and P3, have come to us and said, actually, we think this criteria would actually capture the most people. So wards are starting to use it and adapt it to meet their needs too, which is fantastic. We also have complex patient committee, same panel, multidisciplinary, multi-team, multi-agency. So this is where we take really tricky patients, meet together, pull everybody who's involved, because often they don't just have a ward-based team, they have a lot of other people involved in them. They might also have external agencies involved. We might need to involve Ambulance Tasmania. We might need to do all sorts of things. And the Essendon's case, we'll talk to that a little bit. And it's referral based. And again, it's about having the right people in the room, but also some seniority in the room so that we can escalate all service level issues and address them. So what have we achieved? Well, hopefully we've got a clearer escalation pathway for complex patients, bit of visibility of issues, and I'll show you some data now. And one of the benefits about that is that we've been able to work with the Department of Health to create a new long stay report. The previous long stay report reported everyone with a greater than 35-day last statistical admission, which obviously is never going to cover their whole length of stay. So we want to look at whole length of stay and be able to use that data meaningfully, which is great. So we should have that in the next couple of weeks. We capture key barriers and then we can escalate them. So if we know that a key barrier at the moment is NDIS and delays, then we can escalate that to the right people, and that we can do that not ward by ward or individual staff member, but we can do it as a system, which makes a lot more sense. We can provide I really think in the end, Stranded Patient primarily is an education program. It's a chance to learn about referral systems and what options are here and when things change, which they do all the time, to be able to get that information out in a clinically meaningful context. And we also do things like I look at the top 10 length of stay. So we know who the top 10 patients who have the 10 longest lengths of stay in the organisation are. We can really focus on that. That's actually really helpful. This is our outcomes so far. So this is Health Roundtable data up to December 24. We now have the March data out as well, and that can continue. So you can see that long length of stay starts to tip down at the end for us, and it's back below the 50th centile. So that's very exciting. And the acute relative stay index also tips back down below the 50th centile. So that puts us back really where we'd like to be. What I'd love to see is us to continue to go back down so that we're really comparable with our peer hospitals, which would be really exciting. And we're very close to being able to do that. Health Roundtable data is delayed. So this won't include, this is only going to cover the work that we've done with the 4 medical wards. So we would expect to see some further gains when we've expanded it out, which is great. This is a lovely poster that Health Roundtable did for us when I presented a couple of weeks ago, showing the cost savings. So the cost savings of the original component, which was just the 6 months, they calculated at 12.5 million. Using our number, I think it's probably more like 9, but still it's quite nice. I have to say, Stranded Patient isn't the only initiative that has been put in place in this time. There are many others, and I don't think we can claim all of that. And it isn't released funds. It just is, we've released beds so that other people can use them in an appropriate time frame. But it really all helps us to tell the story that this has been something that we think has really improved length of stay for people who are staying longer than we want them to. Finally, I believe this is a little slide that just shows top 10 length of stay on the left. So this is how long cumulatively those patients in the top 10 are taking. So we can see that we're whittling down that very long length of stay gradually over time. And the one on the right is acute versus subacute. So I'm always interested in where do those patients sit. We'd assume they sit in subacute, but actually initially it was 50-50. Then we had more patients in subacute, and now we're seeing more patients in acute staying for those really long lengths of stay. So that's useful for us, that informs us about how we're going to do things. Finally, this is a spruiking slide. If you have a patient on your ward and you'd like them to be referred to the complex patient committee, you can refer it to this email address, which is appropriately complex.patient.review, or you could just email it to me or to Emma, and we'll find a time to do that piece of work. I'm aware of time, so I'm going to keep handing over straight to Jessica. I think that's straightforward. Thanks, I'll hand over to Jessica.
All right. So I'm Yatin Lewis. I'm going to talk about how Hospital at Home gets involved with patients who've been previously stranded and are now in the community, and our efforts to keep them in the community. So for those of you who may not know, or just a brief reminder of what the Hospital at Home service is, it's a community inpatient unit. We have 30 beds in total, that's 20 acute beds and 10 subacute GEM at home beds. We also run a rapid response service where we go out and see vulnerable people and stop them coming into the hospital, particularly the ED. So, and often they will be discharged after that primary contact. Most of our admissions actually come directly from the community. So we built up enough community referrers that patients who are becoming sick and at risk of being admitted to the hospital are identified by a broad range, don't have to be medical staff, but GPs, community nursing, allied health, ambulance, and they have pathways to refer to us directly. And we go out and see the patient, stop them coming into the hospital. We see about 200 patients a month, and we treat a really wide range of conditions. Our biggest group is probably quite elderly, frail heart failure patients, mostly with cardiorenal syndrome, but there's a lot of soft tissue infections, urosepsis, complex medication management and palliative care in that group. And we operate from 7:30 in the morning to 10:30 at night, 7 days a week. And we have sort of a 24-hour phone line. Now, when it comes to stranded patients, we are involved prior to discharge, and we've been involved with several patients over the last couple of years. They are not always in the hospital, in the Royal. Some of them have been out at Roy Fagan. So we will go out and we don't want those patients coming back here. We'll provide support there. Most have been sort of in the hospital or at the repat. And we come in, we meet the patient, have a chat, explain what we can do in the community. And we discuss their needs with the admitting team. As part of making sure they don't come back, because anyone can ring an ambulance from the community, there's also quite a bit of liaising with the ambulance service. So that name is flagged as to what conditions might land them back in hospital and what conditions can come to us directly. And ambulance refer a vast number of patients to us anyway, so they're quite used to calling us. Then when we get the patient out into the community, we need a way of making sure that that patient is identified to us before it reaches some kind of crisis point at 3 o'clock in the morning. And that can be through the GP, it can be through the sort of care planning with Ambulance Tasmania. Our community nursing teams who are well involved with these patients often also contact us, so they're really good at identifying problems early. And we're then called, we will go out, obviously we finish by 10:30 at night. That means a call anytime before 8:30, 9 o'clock at night, we can react to it. And we can go in and review that person and come up with a plan of how we're going to keep them at home. So, case study, I imagine lots of people here have been involved with this particular patient. Actually, she's now 60, as of not so long ago, but she had been in the RHH for over 1,000 days. She was finally discharged on the 16th of January, and incredibly complex, sort of obese, quite immobile after that, very deconditioned after that very long hospital stay, pretty deconditioned before. CCF, obstructive sleep apnea. She has a obstructive hypoxia. She's on long-term oxygen. She's got a catheter, she gets recurrent urosepsis, she's got chronic pain, and she is highly traumatized by all this and is just like, she's a difficult personality, as anybody who was involved in her hospital stay may recall. So her discharge plan is, because she's under 65, is through the NDIS. And we're looking at 24-hour care, hoists, custom beds, custom wheelchairs, a GP, because that is a real sticking point. We actually need to get a GP for her, and can't thank my community colleague who looks after this patient enough for the work that they do, because that makes all of this possible. And we also have goals of care, which for us, palliative goals of care, ward-based care, for the most part, I can actually provide that in the community. So there's not actually any reason that we need to send her back into hospital. So we can keep her at home. So since she was discharged in January, she's 5 admissions with us. In fact, she's a current inpatient. I was hoping to discharge her before this meeting, but she's might get her out this weekend. So January, February, March, April, we had May off in June. She's only had 1 return to the emergency department in that time. I'll talk about that in a moment. I might just talk about these admissions because most of them are not that straightforward. So arguably she didn't get discharged because we're in inpatient unit and you're transferred to us if you come from hospital on the 16th of January. She was actually discharged on the 20th. She was pretty anxious about leaving hospital. She's been at home for 1,000 days. She's pretty institutionalized. So she's also not brilliantly compliant with her fluid. So she actually fluid overloaded herself in a few days before. So this prolonged planning process, which many people are involved with, got sabotaged. But we did get her out, and we managed her at home, actually with oral diuretics and titrating her oxygen. And after 4 days, we were actually able to discharge her and were able to launch her into the community. And that did okay for a month. A week before this admission, she actually had to go and see her GP in person. GPs are not funded well enough to do home visits, particularly in patients like this. And she had to go and see her GP, which was incredibly traumatic. Getting her into the chair, on the hoist, transferring her by ambulance, waiting to see the GP, all caused a pressure injury. That's how vulnerable she is. She got home now with a new pressure injury, but having seen the GP and now entered into primary care. And a week later, that got infected. So, and when she gets an infection, her heart failure deteriorates and she tends to get quite fluid overloaded. So we went out to see her. We've ended up on some obscene amounts of diuretics through this. We do consult with renal fairly regularly. So she's ended up on a diuretic infusion, IV antibiotics, transdermal analgesia, and a wound management plan. She is at this point refusing an alternating air mattress. It's actually not unreasonable. If you had to sit on an alternating air mattress 24 hours a day, you might also refuse. The foam mattresses are actually much more easy for long-term use. And we kept her out, got her discharged up to 16 days. Very shortly after she is back, again, got fluid overloaded, quite hypoxic. In the middle of the night, our plan failed, and she ended up in ED, which was even more traumatic for the patient than going to the GP because of ambulance response unit, bariatric beds, a long ED stay in an overcrowded ED in the middle of the night. And that made her pressure injuries even worse because whilst her mattress at home is not perfect, it's much better than transferring her to ED on an ambulance trolley and an ED trolley. So We're now back. Diuretic infusion again. I think that was a gram infusion over 6 hours or something, plus or other diuretics. But we had this kind of turning point. She never, ever, ever wants to come to this building again. She's a definite win for me, probably a win for you. 13 days that time. Back in April, catheter issues. She got urosepsis. But she's chronic pain. She's actually on quite a lot of opiates. Her renal function deteriorates quite rapidly, rebounds quite rapidly. This time, very hypoxic, went in, arrived as half of Ambulance Tasmania was there with their response crews. There was 3 ambulances outside. It's looking like she's coming to you. And I had a look at her, and knowing her history quite well at this point, I think she might have accumulated quite a lot of opiate. And yeah, she's completely knocked. He gave her some naloxone. She woke up. I sent all the ambulances away, and we ran an naloxone infusion at home for that day. She was, pretty angry. I messed up her meds the next day, but she was kind of back to normal. And we had her on some IV antibiotics for the urosepsis, naloxone infusion for just a day. We then altered her opiates, so we had less problems if she became had acute renal failure again. And we got her onto, finally, an alternating air mattress. Now, we had improvement within 5 days of some of those wounds on the alternating air mattress. That was in April. And we met May. That was good. She came back on 10 days ago now. Respiratory infection this time. Again, got fluid overloaded. I've been trying to manage her on just oral diuretics when this happens, but that didn't work this time, and she ended up on another furosemide infusion along with increases in her hydrochlorothiazide. To offload that fluid, she's had some IV antibiotics. One good thing though is she's still on, complains about it endlessly, but she is still on the pressure mattress, and all her pressure injuries have healed, so that's good. We are just managing some of her diabetic medication at the moment, but I'm hoping that I might get her discharged this weekend, and we'll see how long she's out for this time. Now, that might seem like a lot of admissions, but she was in hospital for 1,000 days, or more than 1,000 days, and in 168 days since discharge, she has been with us less than a third of the time. So we've had her for 50 days. She has some significant health issues. I have plenty of patients who have similar health issues who are maybe older and not this dependent, and they bounce in and out with this level of frequency. They're all in their last 1,000 days being optimistic of life. So that's not uncommon for the heart failure patients that I see. Because it's mostly me who looks after her at this point, and I knew her as a wound patient many years ago, it's actually been quite easy for me to build rapport with her. I also know her sister, so that has definitely helped with managing her medications, managing her wounds and her pressure injuries. We've learned there's a pattern to her health issues. There's this infection, fluid overload, deteriorating of heart failure. So we've got some kind of recipe to treat it. And leaving home has now been so traumatic for her that she doesn't want to leave. So it's actually much easier for me to keep her at home. We also have a good relationship because her caring team, she is quite difficult. There's a bit of high turnover in her caring team, and they do call the ambulance in the middle of the night. Ambulance now has such a good relationship with us that we get to hear about it. And we have so far, apart from that one admission, kept her out of hospital. And she's had 2 ambulances this week in the early hours, and we've still kept her out. So, what are the learnings from this? Certainly intermittent community inpatient treatment can work for these patients at keeping them out of hospital. You know, they would, without our service, they would probably bounce back in here, and then you are refaced with some of these barriers that make the patient difficult to get out in the first place. I think we could probably go further, and certainly the team has been discussing innovations in the primary care space, which I think our service could be involved in to maybe reduce some of those days even more. If we had a GP attached to our team, probably only about 20 of those 50 days required what might be seen as hospital level care. The rest of it was a bit more primary type care, but that's in our current model is very difficult to provide. So I think there are more innovations and savings that we can do, particularly as we get more of these patients. That's all I've got to say.
Very much. Yes. So yeah. I mean, I think absolutely a big round of applause because it's been a huge piece of work and so great for her to not be here more than 1,000 days is enough in life, but being at home. We all feel often is a better place to be if we can live it right here and there. So I hand over to Sarah Elder now. Hi everyone. I'm Sarah Elder. I am the team leader for the Family Liaison Officers at Dementia Support Australia. I'm missing my colleague Ian Hethery, who many of you know. He's unwell now, but unable to be here today. I've actually noticed every single person in my team joining online in the last half an hour. Anyway, to your slides, sorry. So, we Dementia Support Australia, which is a national service funded by the Commonwealth, and the scope of our service is to provide support to people living with dementia and their carers, with a key focus on changed behaviours that are dementia related. So, the principle of the service is that we want to understand and address contributing factors to those changed behaviours. We've got a range of programs now. We've been around for close to 10 years. And over that time, we've grown from a single program to now 5 major programs. So they go from the Staying at Home program, which provides post-diagnostic support, through to our dementia behaviour support programs, Dementia Behaviour Management Advisory Service and the Severe Behaviour Response Teams. So those programs provide behaviour support across community and residential care. We also assess eligibility for the Specialist Dementia Care Program, and in Tassie that's run at the Waratah unit at Glenview. You may have heard of that. So our role is assessing whether people are eligible for support in that program. And then in the last 6 months, probably more like 4.5, we've been running the Hospital to Aged Care Dementia Support Program, which is a really, really exciting initiative. So the program's been set up in recognition of this issue that I think we've kind of touched on today, and that's the growing number of people living with dementia in hospitals. So the Australian Institute of Health and Welfare tells us that they estimate that about 1 in 8 hospitalisations are dementia related, which is such a huge proportion. You know, there's over 3,500 people living with dementia have prolonged hospital stays as they await suitable placement. So where they can no longer go home. And we know too that delayed transition into residential care can affect the long-term wellbeing of those people and their families. We also know that the transition process typically prolongs hospital stays by more than 20 days due to the complex care needs of the people living with dementia. We've learned a lot in the last 18 months to 24 months. We actually ran a pilot program that's very similar to what we're doing now in 2023-24. And as part of that program, there was quite a bit of stakeholder engagement with acute and aged care sectors. We might assume that the reason that people get stuck when they're at change of behaviours and they're living with dementia is because of residential care bed availability, but that's just really one part of the problem. There's sort of some broader contextual factors. So we now understand very well that the risk mitigation practices that are employed in the acute setting are very different to those that are allowable in residential aged care, and the regulatory requirements are very different as well. The language is very different as well, and the whole philosophy of care is quite different for obvious reasons. So there's kind of, I always like gesture like this, it's like we're not speaking the same language across those two sectors. And so that those differing contexts just mean that the behaviour related barriers are misunderstood between the two sectors. We might also find that client and family preferences can be a barrier, and other factors around that, like substitute decision making, and exposure to aged care. Not many people say that they want to go into residential aged care, and so does that fact of having to move into aged care be a barrier. So we've designed HAC DSP, or the Hospital Aged Care Dementia Support Program, as a bridge between hospital and residential care, and hopefully soon community care. We've been running since around February this year, and we will be delivering the program in 11, and I think it's actually 12 agreed locations across all states and territories. So we've just taken our first few referrals in Perth, WA, just this week, and we're operating in every state and territory except for New South Wales and Victoria, but almost ready to go there. So it's really, really exciting. It's Commonwealth funded, but the Commonwealth has engaged with the state governments to nominate those agreed locations. And in the agreed locations, there are particular hospitals that we're taking referrals from. So under that kind of an aim of being a bridge, we've got some key objectives. They include to promote person-centred and dementia-informed care in the acute setting, but also in residential aged care. We want to reduce that gap in communication, language and understanding. So that's about working on an ongoing basis with the acute and aged care stakeholders to bridge that gap. In terms of what we actually do with the person living with dementia, we want to get to know them in hospital so that they're not going into aged care and unknown quantity, and that's how we promote person-centred care once they move into the aged care setting. We want to be able to translate the risk mitigation strategies that are happening in hospital to suitable strategies for that aged care setting. We do that through the development of a custom transition plan. Then after the transition, I'll talk a little bit more about the pathway in a minute. We're also mentoring staff, and there's a level of that that's also occurring in the acute setting, and we're reviewing the person living with dementia quite regularly post-placement. And we're also supporting the family along that pathway. All right, so who's eligible for the program? People living with dementia are eligible, or people with a suspected diagnosis of dementia and a clear history of progressive cognitive decline. They'll be aged 65 years or over, or 50 years or over if they're Aboriginal or Torres Strait Islander. They'll be an inpatient in an acute or subacute public hospital at an agreed location, and they need to have a current My Aged Care support plan and aged care approvals. And we need the consent of them or their substitute decision maker to participate in the program. We're currently taking referrals from key referrers. So at the Royal here, we work with the Aged Services team, CNCs, at the Roy Fagan Centre, the social workers, and at the REPAP, CNCs on P1 and P2. So we're very much providing a wraparound care. So we've got all these people in our team working to support the transition for each patient. So I've got a team leader who supports the team in each stage, and they're the key point of contact for the program and doing quite a lot of the stakeholder engagement and collaborate with our stakeholders and lead the program. We have a number of dementia consultants in each stage. So their responsibility is to conduct an assessment of the client. They develop recommendations and the plan, and then they monitor the client throughout the transition, and they're the key point of contact for the referrer. The dementia support coaches are gold. So they're our people who are on the ground. So their responsibility really is to get to know the client while they're still in hospital, and to support the dementia consultant to develop the strategies and the plan. Their kind of key point of contact is staff on the floor. And they're really working quite closely, particularly at the Royal, with the patient safety attendants, getting some great relationship building happening there. We also have a small team of family liaison officers nationally, so we can support via phone or face-to-face. And the family liaison officers offer emotional support to family, demystify the whole process, and they also really enable family members to partner in our care of the person living with dementia. We have 3 currently workshop facilitators nationally, so we've got an education piece of work as part of the program, so they provide formal capacity building across acute and aged care sectors. And we've just literally this week engaged medical specialists, so we'll have one medical specialist who's a Canberra-based geriatrician who will be able to support the team through comprehensive clinical reviews for cases, particularly post-transition out, and they'll also provide support and education and medical supervision. So lots of players, and we work very, very closely together. So this is the pathway in the program. So we'll get a referral either via phone or on our web form. It'll be triaged within a couple of days, and then the dementia consultant will be on site at the hospital within 5 business days, and then 2 business days after that, they will have sent a transition proposal to the referrer at the hospital. So that proposal really includes some key strategies to support change behaviours if change behaviours are occurring. It will also include some information on the client's social history, and really that document is designed for the hospital to use in their discharge efforts, and that's sort of, and it forms a basis too for the actual transition plan which goes to the care home. After that assessment occurs, a family liaison officer will reach out to the family, key family member or multiple family members, and then whilst the client remains in hospital, there's a process of kind of ongoing information gathering and development of that plan, very much with the input of the dementia support coaches, and we'll start their visits around the time of the assessment or soon after. We've also got some funding for brokerage, so we can supply some items to support meaningful engagement whilst the client's in hospital and after the transition, and so continued support and planning at that point. And then once the patient is medically stable, cleared for discharge and has an agreed discharge destination, then that transition report or transition plan is finalised and provided to the aged care facility. And post-transition will remain involved in the client's care for up to about 3 months. And that's sort of a similar level of support that we're providing whilst the person's in hospital. So regular visits from the dementia support coaches, regular review, family liaison officer will have ongoing contact with the family as well. And then once the placement's deemed sustainable, that's when we take a step back. Right, so I wanted to talk a little bit about a gentleman called Owen. So he was one of the first people referred to the program here in Hobart, probably one of the first clients nationally. He's 74 years old. He's a diagnosis of probable frontotemporal dementia, and he's got some really significant expressive communication limitations. So we know quite a bit about his history because at some point he was referred to the Specialist Dementia Care Program, and as part of assessing eligibility for that, we do a really in-depth review of his behaviours over time and his management as well. So back in mid-2023, Owen was living in the community supported by his carer. He had been diagnosed a couple of years prior and he started expressing some false beliefs. He was getting a bit worried about his neighbours, thinking they'd stolen his stuff, and he was referred to Old Persons Mental Health, prescribed risperidone, there were firearms on the property that were removed. Remained living in the community through until end of November when he moved into residential respite. His behaviour had become quite erratic in the community, and that was the reason for respite, and they continued to escalate in that early period of respite. He'd gone into respite in a care home that didn't have a secure unit, so that care home felt that they were unable to continue caring for him. They arranged for him to transition into a care home that did have a secure unit, but within weeks of that second respite placement, he was sent to hospital. He was presenting as suspicious with some aggression in that initial part of his admission. He was referred to us for assessment of his eligibility for the Specialist Dementia Care Program, found eligible and waitlisted for admission to Waratah unit. But then, not long after that, his behaviour really started to settle. He had some input from the medical team and the age services team. And then once the program came online, he was referred through HTSP. And actually not long after that at all, he was offered placement in a residential aged care home. So we've supported him over the last 3 months and finally been able to discharge him from the service. His placement certainly hasn't been without its challenges. He's remained very reluctant to accept assistance with care. But some of the outcomes that we've seen through that really intensive support from our coaches and consultants has been that the care team in the residential care home really understands his behaviour in a very nuanced way, and they are really confident to try lots of different approaches with him. They've got a really very detailed approach to trying to provide assistance. He's very keen to stay in his room when he first moved in, but within that first 3 months, he's now coming out and engaging with his fellow residents quite a bit. And his carer as well, there'd been a couple of hospital admissions earlier in 2024, and she'd actually discharged him against medical advice. And speaking to the family liaison officer a couple of times after he moved into care, she did say that she felt like she was going to take him home. So that support from the family liaison officer was also very key in getting him to a sustainable home in his placement. That's it. Thank you. Oh, thank you very much. For attending online, and thanks very much to Sarah and Neston for presenting papers. It's really helpful, and to Ellen for helping us so much of this. We have rescheduled this several times, so it's been a little bit epic. I cannot see any questions there. I know it's 1:30. Any quick questions in the room that anyone wants to ask? Yes.
In a hypothetical situation, if a patient was under 18 but met all the other criteria of Australian patients, so like homelessness, longer than 21, would you still accept a referral and have a look at them and see what supports you could offer?
We'd have to look at it because I'm not sure that we actually understand and know pathways for the under 18-year-olds at this point in time.
But we might be able to get
to
the right people in the room.
You're not saying no, so I'm
And I think that's the whole point of Australian patient is as we keep going and enroll and learn more, we'll be able to learn more and adapt and maybe just facilitate. I mean, in the end, the work, it's not duplicating anything. We don't have to be another MDT or anything like that, but it is a chance to escalate things. So, no, I would say no. Yeah, we would actually think about it and make sure we have the right people to have conversations. That's very much. Thank you very much, everybody. I really appreciate that.
There's one.
There is one.
Scroll.
Oh, okay.
It's a bit behind, Sally.
That's the thing. Let's go up. Here we go. Oh, that's long. Oh, it's from now. So, having participated in some of the Australian patient reviews, as I said, has much potential for growth in education, social service areas. Feel very seen. You should feel seen. Social ethics is so integral. Would there be potential for these patients? Factors quality improvement reviews and similarly to the medical and meetings and teams could really, absolutely. I think that's a really great idea, and we had talked about it in Allied Health. I'm not sure if we would want to make it just Allied Health, though. In some ways, when we set it up, they might not be M&Ms, but the complex review of somebody once they've gone and what can we learn from this, I think is really important. So it's definitely on our radar, and it's nice to know that other people might think that that's useful too. Yeah. So much to do.
Would you like to go?
Okay, thank you very much for coming along. I really appreciate it. Thanks for listening.